Thank you very much, and thank you for inviting me. It's not my first visit to Poland, but it's my first visit to Krakow, and I have to say that it's a really very beautiful city. And I also wish to congratulate Arthur for his dynamism. He's really a fantastic ambassador of Poland and of Krakow. I will focus on post-autologous transplantation. And the first slide is just to show that if you consider that autologous transplantation remains a standard of care, and my understanding after Kwei-Young's speech is that yes, it remains a standard, at least in many cases, and at least for progression-free survival. So if it is a standard, it is part of a very complex procedure with an induction therapy, and this slide shows the current standard induction therapy. The consolidation after transplant, either with the same drugs as used for induction or with a second transplant, and maintenance. And as you already heard, the objective of post-autologous transplantation treatments are to increase the response rate and the minimal residual disease negativity rate, and maybe even more importantly, to maintain the response and to maintain sustained MRD negativity. So what is the current standard? The current standard is low-dose lenalidomide, 10 to 15 milligram per day. And many randomized trials have shown that lenalidomide maintenance improves the progression-free survival versus no treatment. And meta-analysis of 3 major trials showed that it also improves, which is very important, the overall survival, but you have to wait 5 years before seeing a difference in overall survival. So based on this trial, lenalidomide maintenance is a standard, but there remains some question, and especially regarding the duration of maintenance, fixed or continuous, and the benefit in some patients, especially in high-risk patients. But the most important question is that we now have new drugs which could be used either in place of lenalidomide or in addition to lenalidomide. So I will try to cover these fields. So first, what is the optimal duration? I think that in the United States is always until progression, but in the real life, the median duration of maintenance is roughly 3 years. In the determination studies, the median duration of maintenance treatment was 3 years. In Europe, usually the duration of maintenance is fixed, 2 to 3 years. Because of some concerns regarding long-term treatment. Of course, tolerance. There are patients who have chronic fatigue and we are pleased to stop the treatment. The issue of second primary malignancy and the hypothesis of the clonal selection, and of course the cost, which are very important in many countries. So no randomized trial addressed the question of fixed versus continuous. However, as you already saw, it's possible to answer the question, at least partially, by comparing the French IFM 2009 trial and the determination trial recently published. This slide shows the 2 trials. The induction autologous transplantation consolidation was the same. The only difference was the duration of lenalidomide, 1 year in France, because we were concerned by the risk of second primary malignancies, and until progression in the determination trial. The results have been shown. The progression-free survival was superior in both arms, autologous transplantation and non-intensive treatment, in the US trial compared to the French trial. So we can conclude that prolonged duration improves progression-free survival, but as you already saw, there is no difference in overall survival. Coming to the new drugs, first, it's possible to use proteasome inhibitor. And this slide shows the results of the tourmaline MM3 published by Thanos Dimopoulos in 2019, comparing no maintenance to ixazomib maintenance. And you see that there was a benefit for ixazomib maintenance, but which was not striking. It was significant, but the meaning, the clinical meaning, was questionable, and my personal feeling is that the benefit was moderate. So maybe this one is more important. It's part of the Spanish trial, the GEM 2014, regarding maintenance, and there was, as you already saw, a randomization between Revlimid plus low-dose dexamethasone versus the same plus ixazomib. And you see that there was no difference in terms of upgrading to complete response, of upgrading to minimal residual negativity, and no difference in terms of progression-free survival. So the conclusion for the time being is that there is no benefit of adding ixazomib to lenalidomide dexamethasone compared to lenalidomide dexamethasone alone. Second proteasome inhibitor, carfilzomib, and the most important trial regarding the use of carfilzomib is again the Italian Forte trial. You already showed the design with the first question regarding the first part of treatment, either non-transplant or transplant with KCD or KRD induction, but I will focus on the maintenance question, the second randomization, which compared classical lenalidomide to lenalidomide plus carfilzomib. And you see on the left inside of the slide that the progression-free survival was significantly better with the doublet carfilzomib Revlimid compared to Revlimid alone, and this was true across all prognostic subgroups. The Polish investigators work with a Polish expert working in the United States, and they designed this Atlas trial, which was again a comparison of KRD versus Revlimid. And you see on this slide that the KRD post-transplant was superior to Revlimid in terms of progression-free survival. Another possibility is to use the anti-CD38 antibody after transplantation. You already saw the Cassiopeia trial. The first question was DARA VTD versus VTD for induction and consolidation. But there was a second question regarding maintenance with daratumumab or no daratumumab. The overall result is that the daratumumab maintenance is superior to no maintenance, the red curve compared to the blue curve. However, in fact, there were 4 arms: DARA without maintenance, DARA induction and consolidation without maintenance, DARA induction and consolidation with DARA maintenance, VTD without maintenance, VTD with maintenance. And if you look at the right inside of the slide, you see that there was no benefit of using DARA maintenance if DARA was used for induction and consolidation. So currently, if you use DARA for induction and consolidation, you don't need daratumumab for maintenance. There are other possibilities with daratumumab, and for instance, you can add daratumumab to lenalidomide, and this is on the left-hand side, the Griffin trial you showed already. Patients were randomized to receive RVD for induction, consolidation, and Revlimid for maintenance, or Dara-RVD for induction and consolidation, and Dara-Rev for maintenance. And the ongoing large randomized phase 3 trial, the Perseus trial, is almost the same design. Again, patients who receive daratumumab for induction, consolidation, and maintenance, and patients who don't receive daratumumab for induction, consolidation, and maintenance. And I do personally think that these trials are important, but they will not answer the question of the impact of daratumumab maintenance since patients receive daratumumab during the whole study. So I think that the following trials are maybe more interesting for answering this question, Dara plus Len versus Len. This is the Auriga phase 3 that you already saw, and it will address the question of the impact of adding daratumumab to lenalidomide. And the primary endpoint will be MRD negativity conversion, and there is another one from the SWOG trial, which will compare daratumumab and lenalidomide versus lenalidomide after transplant. And in this particular trial, the interest is that patients, the duration of maintenance will be defined by MRD negativity. And at 2 years, patients who are MRD negative will be randomized between stopping treatment or continuing treatment. And it is a very important question, especially regarding the cost of treatment. I do personally think that with this long-term maintenance treatment, the question of cost and of adverse event is very important. So I think that it is very useful to have MRD-driven maintenance therapy, and this is the design of several trials which are ongoing, in which the decision is driven by MRD assessment after autologous transplantation, consolidation, and usually 2 years of maintenance. And the strategy will be different for MRD positive patient and MRD negative patient. But in MRD negative patient, there will be a question of stopping the treatment versus continuing the maintenance treatment. Another question is to adapt the maintenance to the risk. I said that there are some concerns regarding the efficacy of lenalidomide in patients with high risk, although the British showed that lenalidomide maintenance was also useful in high-risk patients. But some consider that high-risk patients should be treated differently, and these are two examples. Our own trial, the Midas Trial, the primary objective is to define the treatment after MRD assessment, but there is, in the high-risk patients, those who are defined by MRD positivity after 6 cycles of a quadruplet, there will be a different maintenance treatment with a doublet isatuximab iberdomide instead of lenalidomide. The other example, and there are many others, but this is a German example. In this trial, again, the maintenance is reinforced for high-risk patients. So this is the current situation, but maybe things will change very rapidly because we have now immune therapy, and this is an example of a trial in which the bispecific T-cell engager antibody teclistamab will be tested after autologous transplantation, and it is a Majestic 4 trial, which is developed by the European Myeloma Network, which will compare the standard lenalidomide to the combination of teclistamab plus lenalidomide. So in summary, lenalidomide is a current standard, should be prolonged for at least 2 to 3 years. Maybe the result of lenalidomide maintenance could be improved by the addition of carfilzomib or an anti-CD38 antibody. And I think that for this very expensive maintenance, the duration should be driven by MRD negativity. A few words regarding consolidation. We have 2 trials who compared consolidation after transplant. Consolidation meaning repetition of the same treatment as induction. The first one is a US stamina trial, which actually compared no consolidation, consolidation with VRD and a second transplant, and the European EMNO2 trial, which addressed the question of VRD. The results are different. You see that in the stamina trial, there was no difference in progression-free survival, no benefit of consolidation or of tandem transplant. Why in the EMN study, there was a benefit of adding 2 cycles of VRD after autologous transplantation. I think that the difference was the treatment before transplantation. And in the US trial, the treatment was often VRD and for a long period of time, while in the European study, the induction treatment, in my opinion, was suboptimal with only 3 or 4 courses of VCD, but not VRD. And I think that the impact of consolidation greatly depends on the efficacy of the induction. And for instance, again in the Spanish trial, they used 6 cycles of VRD induction, more effective than 3 cycles of VCD. And the impact of consolidation was minimal. You see, after autologous transplantation and after, I'm looking for the pointer. You had a pointer. This one, okay. So you see that after autologous transplantation, the VGPR rate was 75%. After consolidation, no major change. And the same was true for MRD negativity. So if the induction is very good, maybe you don't need consolidation with the same drugs. This was with triplets. With quadruplets, what is the situation? You have here the results of the Cassiopeia trial with a quadruplet DARA VTD, the Griffin trial with a quadruplet DARA VRD, and the Master trial with a quadruplet DARA KRD. In all these 3 trials, the maintenance with the same quadruplets did improve the response rates and the MRD negativity. So the question is, what is the optimal number of quadruplets? Is it 6? Is it 8? Do you perform 4 before autologous, 4 after, 6 before, 2 after? I don't know, but what is important is that the results with 6 to 8 quadruplets is better. Very rapidly, double transplantation. Again, the stamina trial, as I said, no benefit of tandem transplant versus no consolidation. While in the European trial, this was published by Michele Cavo 2 years ago, there was a benefit in terms of progression-free survival in the group of patients who received tandem transplantation. But it occurred, and you see the PFS and the overall survival. But it was shown that, in fact, this benefit was mostly for high-risk cytogenetic patients. And you see the striking difference in favor of tandem autologous transplantation in this particular trial in high-risk cytogenetic, including deletion 17p. So that is the reason why in our current Midas trial, we asked this question of tandem transplantation, because the EMNO2 was performed at the time of triplets. Will the situation be the same after quadruplets? We asked this question. We gave 6 cycles of quadruplets, isatuximab KRD. We look at MRD after 6 cycles. there is a question regarding the interest of autologous transplantation, as Kui-Yang said, in MRD negativity, do we need autologous transplantation? But in patients with high risk because of MRD positivity, we will address the question of tandem transplantation. And the next step, again, is possibly the use of immune therapy for maintenance. And you see the design of the MASTER-2 trial developed by Luciano Costa. And he will use teclistamab daratumumab for maintenance and teclistamab daratumumab for consolidation as well. So maybe in the future, immune therapy, including bispecific antibody, will replace the classical way of post-transplantation treatments. So the summary regarding consolidation, when using the same induction regimen for induction and consolidation, the impact of consolidation depends on the result of induction. With quadruplets, I do think that the 6 to 8 cycles of quadruplets do improve the response rate and the MRD negativity rate, and maybe the introduction of T-cell engager antibody may offer a new possibility. And I finished by the slide which was already shown by Dr. Kui-Yang. Maybe the most ambitious use of immune therapy will be to use CAR T cells instead of autologous transplantation in the future. With that, I thank you for your attention.
Thank you very much for lecture. The paper is open for discussion. Any questions, comments? Professor?
Professor Harousseau, you have a huge experience in myeloma. What would you advise a patient age 38?
You said
which
38?
policy? Go to a trial, and which direction to go?
I didn't understand.
Would you advise him to be treated stepwise with all possible drugs, then after proceed to autologous transplant, or look for a donor for him and make allogeneic transplant? Because the number of younger patients is increasing, and they ask not only for treatment, but for cure.
Yeah, well, it's a difficult question. I'm aware that allogeneic transplantation can cure patients. I also understand that it's better to use allogeneic transplantation in younger patients. However, there is still a risk of toxic death and of chronic graft-versus-host disease. So allogeneic transplantation remains dangerous. And at the time, in 2022, when we have so many new drugs, and especially so active quadruplets, I do think that it is possible to obtain cure without allogeneic transplantation, and I will not recommend allogeneic transplantation, except maybe in plasma cell leukemia or double hit cytogenetic abnormality. But currently, I would prefer to use quadruplets with anti-CD38 antibody upfront, autologous transplantation, consolidation, and a good maintenance. And we already, David Vezol showed the patients who are still alive 20 years after a double autologous transplantation. But we now have fantastic results with MRD negativity sustained for 3 or 4 years, and we can hope that this patient will be cured. So I would stick on allogenic with quadruplets.
We are waiting for a cure in myeloma for many years, and I feel that we are very close to this situation. And what is your opinion? Because regarding patient point of view, a patient needs the best therapy and fixed duration therapy, because the therapy forever, it's not the best, of course. When you have a choice, it's, for example, 50, like my age, 50 years old gentleman, and you can offer him the best induction therapy, DARA KRD, DARA VRD, and DARA VCD, or DARA VTD. What's your choice?
Well, in France, we have used DARA VTD, and DARA VTD is cheaper than DARA VRD, so it's a good point. Which is the best? There is no randomized trial, so we cannot answer the question. It's possible to compare results, and well, my personal opinion is DARA VRD is probably superior to DARA VTD. What about DARA KRD? There is a general feeling that DARA KRD will be better than DARA VRD, or carfilzomib is better than bortezomib. What is sure is that carfilzomib is much more expensive because bortezomib is generic, so it's very cheap. And I'm not sure that carfilzomib is really superior to bortezomib, especially because we don't know which dose of carfilzomib. Is it 36? Is it 56? We don't know. So if I had to choose out of a clinical trial, I will say 6 cycles of DARA VRD, autologous transplant, 2 cycles of the same DARA VRD, and maintenance with lenalidomide. I'm not sure that if you use daratumumab up front, you need daratumumab for maintenance. So I will say lenalidomide 3 years.
It seems that autologous transplantation remains a treatment, a standard treatment, especially in high-risk patients, probably seeing the data. So my question to you is, of course, it's maybe a speculation, but how do you think if a maintenance will change in the future? I'm thinking about the bispecific antibodies. Do you think that they have a potential, especially in high-risk patients, if they use early on, right? Because now we use it late in 3rd, 4th line therapy, and still they do respond. So do you think, of course it might be a speculation, that instead of giving lenalidomide, or maybe lenalidomide with bispecific, we can, let's say, improve the outcome of these high-risk patients, not doing the second transplant? How do you think?
We asked the question of tandem transplant in the Midas trial for patients who are not MRD negative after 6 courses of the best treatment, DARA KRD. So yes, maybe it would be for high-risk patients or for patients who do not achieve MRD negativity after 6 courses. It might be a good idea to try and confirm the results of the EMN trial. Tandem transplant is superior to single transplant. Another possibility might be immune therapy. In those patients who are MRD positive after autologous transplantation, immune therapy might be very useful. The problem we have in all countries, including the United States, is that CAR T cells are not readily available. Currently in France, we have CAR T cells only for end-stage patients and only a limited number per month. Of course, this will change because we will have cilta-cel in addition to ide-cel. But again, even with cilta-cel, the patients are not cured. They relapse. So you have seen that the prospective CARTITUDE-6 trial, they plan to give lenalidomide maintenance after CAR T-cell. I don't know what will be the feasibility, but it is the objective. So it may be a hope, even for, and especially for high-risk patients, but of course it's just speculation.
Are any other questions? Professor Jędrzejczak, please.
I have actually questioning, what is your opinion about using autologous transplantation as salvage therapy? And probably with the advent of increasing number of new drugs to change paradigm in this way, that this would be in general, in the standard, autologous transplantation will become just salvage therapy after failure of all these lines of therapy that we currently have available.
I'm not sure. I cannot hear.
Salvage therapy. Bone marrow transplantation,
Yeah.
high-dose melphalan as salvage therapy.
Oh, yeah. In patients who don't receive the autologous transplant. Yeah.
These days, as we have frequently collect more cells and they are stored.
Yeah.
And after 3-4 years, we still have cells, but patient is already resistant to inhibitors, proteasome inhibitors, lenalidomide, blah, 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 and other. And then what we can do?
In France, we don't have a great experience of salvage autologous transplantation in patients who did receive transplantation up front. And I think that in the British trial, the comparison was not good because the non-transplant arm was not very active. So I don't know for salvage autologous transplantation in patients who receive autologous transplantation up front. In patients who didn't receive autologous transplantation, we try to perform the transplant at the time of relapse, but as it was mentioned, this doesn't change the overall survival. So I'm not a great fan of salvage autologous transplantation, especially now that we have so many possibilities, so many new drugs, and in the future probably more possibilities with the immune therapy. Myeloma is becoming an immune therapy disease. So at the last IMW meetings, the number of presentation regarding immune therapy was impressive, and it will be the same at ASH. So instead of salvage autologous transplantation, probably in the near future, we will use immune therapy.
My question is regarding, you mentioned that in end-stage patients, you offer CAR T-cell at the moment in France. You have the big experience from 80s until now. In the past, normal duration of survival in myeloma was like 3-5 years, and it was very short. Now it's much better, of course. And I am asking about hospice therapy. How is regarding end stage hospice therapy at end stage? How is organized in France in myeloma?
It's not organized at all. It's not organized. No. We are always trying to find a solution. We are always trying to give a chance of prolonging life. But of course, there is a moment where there is no hope. So usually, but it's not organized.
You treat on the hematology clinic until end?
Yeah.
Yeah, okay.
We try to propose 6-line, 7-line, 8-line trial.
Understand.
Perhaps I might ask a question. It's about your Midas trial. So, about the Midas trial, yes, the IFM Midas trial. So, in that trial, the MRD positive patients after induction are considered high risk, and the MRD negative patients are considered not high risk. But what about patients who are ultra high risk on their genetics? Because we can see from the master study that if you stop after MRD sure, patients with ultra high risk will relapse. So is there a argument to be made for regarding ultra high risk patients differently?
I think that the British were pioneers in defining the ultra high risk, and I think that it is a very important question. The reason why we decided to make a dynamic approach of the risks, which means to consider high-risk patients as patients who don't respond to the best induction treatment, is precisely because we were not able to find the right group of high risk. It's very difficult currently to define the high-risk group, and even in the studies you showed, there were high-risk patients, but the definition of high risk was not the same, especially regarding 17p. You have, in many trials, the proportion of patients with 17p is not the same because the percentage of positive cells are different. So I think that we still don't know who are the high risk, and there is an urgent need to reach a consensus regarding the definition of high risk. So that's the reason why we decided, for instance, not to use RISS, because we thought it's not a good stratification system, prognostication system. But we have our own system. There is another system in Europe, the RISS2. So it's too complicated. So we decided to use a dynamic approach, defining high-risk patients by the response to the induction treatment. But you are right. I think that double hit or ultra high risk are different. And if you design a trial focusing on ultra high risk, I think you're right. I think you should treat ultra high risk differently. And in the near future, we will have standard risk, moderate risk, and ultra high risk. And those patients need certainly a different approach, as you do in England, in UK.
Yes, but possibly those ultra-high-risk patients will not achieve MRD negative anyway, so then they will fall into your high-risk group.
Or they achieve MRD negativity, but for a very short period of time. Yeah.